Respected Chair, AIOC, thank you for this opportunity. I'm going to be talking about what's new in ROP and mostly in the Indian perspective. So these are the aspects I'm going to cover. We'll quickly get into that. So the new classification came last year in October. I'm not going to delve into the entire classification, only what's new. So there's actually a table in the manuscript, and this is for a free download, on what's new from International Classification 3 compared to the older one in 2005. What's relevant to us? Aggressive ROP. In fact, the name APROP is now replaced by just AROP, showing that the disease can also happen anteriorly. So let's just go, instead of these definitions, let's go to the images that are there in the manuscript. We're also very proud that India was represented in this group. And in fact, these images have come from our country. So a lot of the capillary non-perfusion, a lot of the occlusive type, and the hybrid type of ROP that has been described from our country first has now made it into different subtypes of aggressive ROP. The next thing is the new thing, terminology of regression. So regression can either be complete, whether it is spontaneous or after treatment. Complete regression means that the blood vessels have reached the ora serrata, or it's incomplete. So here there's a new term called persistent avascular retina, or PAR. So PAR is something we'll have to start dealing with, because especially as we start giving anti-VEGF injections, a lot of these, majority of these rather, are not going to vascularize till the edge of the retina, and they're going to remain as persistent avascular retina. What to do with them is another topic all itself. The second new terminology is reactivation. Now, reactivation is something that became better and then reactivated. Now, reactivation is either most commonly, again, seen after anti-VEGF. So I think that's important to know. And reactivation can be either the coming back of the disease fibrovascular proliferation, or the vascular signs of plus, or sometimes a completely new sign. And this reactivation can happen in the older site, a completely new site, or at both places. So it's rather confusing, but at the point we have to remember that follow-up is important. New imaging devices, this is again a pride of the country. It is now an CE and FDA approval for more than 5 years, more than 2,000 installations across the world, and this is now coming in with a angiography model. As anti-VEGF becomes an important tool in our armamentarium to treat ROP, and fluorescein angiography is going to play a very important part in deciding which of these babies might primarily be used for anti-VEGF and how to follow up. The other innovations coming from our country are these. One is called the MII RedCam. It's actually a cell phone based. It's not wide field. It is user dependent. It's not linked to telemedicine platforms, but it's useful for photo documentation. A almost similar device is the C3 from Ahmedabad. Again, this has a slightly more adaptable hand piece where you can alter the distance between the phone and the lens. Again, it is dependent on the 20 diopter lens, and so there are these disadvantages. Newer imaging techniques, I'm just going to delve into few. This is an example on the upper left, is a eye that has been injected and incompletely lasered, and you can see that otherwise it looks innocuous. Oh, it's fine, there's not much disease. But look at the angiogram of that same case, and you can tell how active the disease still is. You can see how avascular some areas are and how the leakage is still going on. This is some work that we've been doing on OCT. Handheld OCT has really helped us understand fovealization, or that process of the foveal dip occurring somewhere between the expected due date and about 52 weeks. So in the first 2 to 3 months after birth, after the due date, the foveal, so-called foveal reflex or fovealization should occur. Now, about 20 to 30% of these babies, and these studies have been now replicated across the world, come up with this, what is now called macular edema of prematurity, or MEOP. Now, this is transient. It can usually happen between the 34th and 42nd week, but its effects last for a very long time. In fact, when we followed up these babies for a year, we found that these babies are sort of disadvantaged for lower vision measured on telar acuity, and also have slightly higher chance of being hyperopic at the end of the first year, even though the edema was just for a few weeks. So why and what? All these other layers will also tell you. For example, the non-fusion of that inner limiting layer with the outer plexiform layer, that blue arrow, and some other changes in the outer retina can all happen when clinically these maculas and foveas look normal. This was our foray into OCT angiography. This was the first time we did it on a really tiny baby with the baby held up. And what we showed here was that now that we are able to image the deep vascular plexus, we find that this so-called flat new vessels of APROP or AROP are actually deeper. we went on to look at what these OCT angiography findings look on for slightly older children. On the left are control babies who've never had the disease. In the middle are those babies who've had the disease and have had 6/9 or better vision after laser treatment, and these are all age 5 to age 10. And you can see how the FAZ is completely obliterated. So they're clinically normal, their vision is normal, and yet their foveal anatomy is not normal. And this is picked up on more sensitive imaging techniques like the OCT angiography. This is one of our theses of our students that has now got published, where we looked at contrast in a baby during ROP screening using these special contrast cards, and we linked that to poorer vision. So children who've had lower contrast or impaired contrast during the initial screening phases have actually had higher chances of developing ROP and have had poorer vision in the 3rd and 6th month after follow-up. So how does this contrast, which is supposed to be a macular phenomena, mimicking what's going on in peripheral avascular retina and then eventually coding for what the disease may be, is very interesting, unanswered research questions. As far as predicting ROP is concerned, we've been doing some work with our basic science lab in Bangalore, where we have taken these tears of these babies, and you'd be astounded that we can get tears in babies who've still not developed their lacrimal gland secretion. And these tears are now analyzed in our laboratory for about 10 molecules. Some of them are proangiogenic, some of them are just inflammatory mediators, and we've now come to a point where we can predict which of these babies, based on their first tear secretion, will eventually develop the disease. What we are hoping to do is prospectively figure out which of these babies will end up requiring treatment. You can imagine how useful that will be. In the first screening itself, you take their tears, and then you can tell the mother, look, your baby has a chance of developing ROP 4 or 6 weeks later. This is work in progress. The initial part has been published in IOVS. I want to talk about a little bit of the legal aspects. It's so important. We have a publication coming out of the Indian ROP Society. This is now available for a free download in the APJO. These are about 6 cases that have gone horribly wrong in our country, right from about 24 lakhs to 1.8 crores that went against pediatricians, and in one case against the ophthalmologist itself. What we hope to bring out in this publication is how you can prevent that litigation. Now, this is obviously not foolproof, but some of the pointers are here. In terms of consent, what is an ideal documentation, how do you safeguard yourself based on the kind of practice you are in, whether you have a camera or not, and what kind of documentation you leave in the inpatient file, what you give to the parent, and so on. I'm really rushing here because this is up for a free download. I just want to end probably with what we changed during the pandemic. The Indian ROP Society came out with new guidelines. What we didn't change is who and where to screen, but we did modify the patterns of when we can call these babies for follow-up. And I believe that we were one of the few countries that managed to continue ROP screening despite, even I'm talking about, in the first wave. And I think it's something that we're very, very proud of. In the last week of March in 2020, the IROP Society came out with guidelines, and which was eventually inculcated into the AIOS guidelines for other diseases as well. So what we changed was we brought down the threshold for when we need to treat. We said how the follow-up can be modified, and this is our team here trying to treat a COVID positive baby. And look at the date, it's April 2020, when we just went into the first wave and we had no clue what this pandemic was all about. I'm going to end with artificial intelligence and ROP. So again, some work we've been doing in Bangalore initially was just image enhancement, trying to look at these poor quality images better. But today we now have an ability to look at these images in an AI model. We are able to now predict which of these, you throw in the image into the AI model and it's able to tell whether there's disease or no disease. If those who attended the ROP session just prior, this was being discussed. Now what is work in progress is that the sensitivities are here, they're in the early 90s, and we hope to improve that in the times to come. Thank you very much for the opportunity.
Thank you, Dr. Anand Vinekar, for excellent presentation. Dr. Anand Vinekar, he did MS from PGI Chandigarh, so he was our alumni. And Professor Dogra, he did all the training in ROP from Professor Dogra. And from Narayana Netrale, he is among the top in the, I think his outstanding work is globally recognized. Thank you so much.
Thank you, sir.